Thank you so much for the kind introduction. Good afternoon, everybody, and I'm very thankful to the organizers for calling me here. So I'll be dealing with the recent updates in PCOS. And as we all know, Polycystic Ovary Syndrome or PCOS is the most common endocrine disorder affecting women. The prevalence varies from country to country, according to ethnicities. But if you look at the three pillars, we know it's hyperandrogenism, insulin resistance, and anovulation. Now, this insulin resistance, hyperandrogenism, and anovulation, the problems in GnRH pulsatility, all of these, as we know, are very closely intertwined. Now, what triggers what is like asking the chicken and egg question. Nobody knows that clearly, but we know there is a lot of contribution from genetics, epigenetic changes, and multiple environmental factors are becoming more and more prominent as triggers to the pathogenesis of PCOS. So, when we were students in endocrinology, we used to read the 2013 Endocrine Society guidelines, and this is possibly the only guideline that has been declared as retired by the society itself. And in 2018, the International Task Force-based guidelines of PCOS came out, which was endorsed globally by almost all prominent endocrinology as well as gynecologic societies across the globe. And this was recently updated last year, which makes my job easier as I will just be highlighting the changes that have occurred between the two. So let us look at two hypothetical cases. This is the tale of two sisters, a 25-year-old lady, obese, having a sedentary lifestyle, having oligomenorrhea since her menarche, on and off combined OCPs prescribed by some doctor or the other, having increased facial hair, which is concerning to the patient, and a family history of diabetes. And this is her sister, her younger sister, 21-year-old, non-obese, more or less an active lifestyle, having oligomenorrhea for the last 5 years, increased hair over her face as well as to some extent on her body, as well as having refractory acne on her face, and again, of course, they belong to the same family, so they have a family history of type 2 diabetes in their parents. So, as we know, talking of the diagnostic criteria, these are the three criteria we all read about, but more or less it has been accepted that the Rotterdam criteria is the criteria to be followed. This is almost accepted everywhere now. And so any two of oligoanovulation, hyperandrogenism, and imaging detection of polycystic ovarian morphology after the exclusion of common secondary causes like thyroid dysfunction, hyperprolactinemia, and some of the other endocrine disorders that can mimic PCOS to some extent. So talking about anovulation or oligoovulation, so before we declare somebody as having oligomenorrhea, it's important to understand what a normal menstrual cycle interval constitutes for that particular age group. So between 1 to 3 years post-menarche, anything between 21 to 45 days would be normal. Before that, irregular menstrual cycles cannot be officially defined. After 3 years, after menarche, till the perimenopausal age, anything between 21 to 35 days is normal, and anything more than 8 cycles in a year is normal. And in more than 90 days for any one cycle would constitute as an abnormal menstrual interval, and any patient after 1 year of since menarche. So ovulated, the new guidelines state something that we often commonly practice, though it's in a different context, but that it has mentioned that ovulatory dysfunction can still occur in patients with otherwise regular menstrual cycles, and therefore it's important to document anovulation with mid-luteal serum progesterone. Now, this is something which we sometimes do to document whether a patient is ovulating or not, but this has now come in the guidelines as well. We know about the different phenotypes of PCOS, and though there is a lot of overlap between these, but phenotype A and B, as you know, they are more severe with greater cardiometabolic risk, and obesity and ethnicity can have strong modulating effects on these phenotypes.